So I think Phil was talking about definitions. What do we understand about end of life, about dying, around about palliative care? And I'll come to that later. I'm going to talk a little bit about what we've done in Scotland, particularly around about the health service, recognise some successes and some of the enormous challenges that I think all of us face when we are, I'm a GP, when I'm working with people and families who are distressed, whose needs are changing, who's with such a lot of uncertainty. But also, I think today is about actually what we can think about, our choices about how we live well and perhaps how we might die well. But let's not forget, whatever we read anywhere, is that actually the mortality rate is 100%. The one certainty that we have in life is we will die. 7 billion people living in the world, that's an awful lot of death that's going to be happening all around about us. But things have changed radically. I mean, I graduated a long, long time ago when the death from heart disease was at its peak. And it is absolutely incredible with technology advances, with medical advances, that the number of people dying from coronary heart disease in Scotland has literally fallen by half over the last 25 years. And if you think of people's experiences, if they have chest pain, have heart attacks, they have stents, different drugs, it has been a huge revolution in the difference in ways people die. But also that means that many more people are living much longer with hearts that don't work as well, go into heart failure, cause breathlessness, fatigue, nausea. And heart failure is one of the big areas that we actually need to recognise as being an important cause of death. But I think the other thing that we need to touch on, and Phil kind of outlined it, is we've got to think about what is actually happening in various parts of Scotland. This is a slide that Dr. Burns, the Chief Medical Officer, uses to try to to get some thinking about what is actually happening in areas of Scotland. When we talk about the inequalities or the variance in the average age of people's death across Scotland, this is a slide which looks at Glasgow compared to Liverpool and Manchester, and we have significant higher numbers of people dying from suicide, alcohol, and drugs-related poisoning. These are kind of areas that perhaps we don't think about, particularly when we're looking at palliative and end-of-life care. And actually, how do we as a society recognise the huge impact that that increased rate of deaths from these very difficult areas have on our society? And again, that's backed up by actually if you see this line here, the dramatic increase over the last 10 or 15 years of people dying from alcohol-related liver disease. So although that much of what I'm going to talk about is pertinent to people who are perhaps at their end of a natural life, who are living with many different conditions and gradually coming to the end of their life, we must be mindful not to forget the impact and what we can do or think about differently for different parts of our society. I was very proud to be involved in the development and writing of Living and Dying Well. Living and Dying Well is the National Action Plan. It's supported by the Scottish Government Health Directorate that lays out the obligations across Scotland's health system, both within primary, secondary and tertiary care, to work together to support people and their families in the most joined up way we can in identifying people who are coming to the end of their life, to assess their needs, not just their physical needs, but their emotional and psychological and practical needs, and actually address those needs by coordinating care around about them and coordinating between ourselves so that we can really try and support people as much as possible coming towards their end of their life. We've also got a perception issue, is that for many people, we, as a health service, and I think I would be part of that, actually drove as much curative treatment as we possibly could without recognising that people were changing, that their needs were changing, their health was deteriorating, their function was deteriorating. And then there was this sort of, particularly perhaps in the oncology services, the cancer services, to say, well, we can't do any more for you. Go and get some palliative care because you're going to die. And I think that's a huge perception issue that we need to challenge ourselves about, all of us, that actually, if we have got a diagnosis, any of us, of something that is going to affect our ability to function as we would wish to and bring us towards the end of life, then we need to open up our discussions. And I'm talking about me as a person, as a daughter, I'm talking about me as a doctor and as a national clinical lead, that actually, let's be honest, that things are changing. Your health, you aren't able to do what you did 10 years ago, 5 years ago, last year, but actually, what is it that's important to you, and what can your family and your community do round about you, but actually, what can the health and social care services do to support you as well? This is not, for me, a health care issue. It is about all of us supporting each other and your interactions with healthcare being as good as they possibly can be. And then if you drill down, that there are different patterns of how people come to the end of their life. If you think about somebody perhaps you knew who had cancer, they perhaps kind of, at the time of their diagnosis and doing that initial treatment, really maintained reasonable health, reasonable function. And then something happened, whether they had local spread or wider spread disease, and then really there was inevitability that they would deteriorate and come to the end of their life. And that's the model that most hospices have actually built up their expertise, huge range of expertise about. And that line could be going over there, but there is that sort of ability to say, this is what's happening, let's plan it, let's think about what is important to you. But increasingly, more people are having this sort of pattern. So if you think about somebody who has perhaps advanced lung disease, who has a sudden infection in their chest, they've become very breathless, very unwell, very quickly, very scary times for them and their families, often come into hospital very rapidly, very unwell, but actually get better. And then it happens again. But actually, if you take a stand back and look at them, actually, overall, they're deteriorating. And it is these times where actually, I think, as a healthcare service, we're not so good at actually having those conversations. To say, actually, if you look back to how you were 6 or 8 months ago, you're not as good. You've had a couple of emergency admissions. Is that what you want to happen next time? How do we want to plan this? Is there anything that's more important to you that we can look at doing differently? Because what families say to us is that, gosh, every time he's come in really unwell, he's got better, but he died this time. And the time for planning, to saying goodbye, to say the things that are important, perhaps don't happen. But increasingly, we live with an older population, perhaps who have cancer and heart failure, and who are deteriorating gradually but inevitably towards their end of their life. Many people will have cognitive impairment, perhaps the time for conversations, significant conversations has gone. How important it is to have those conversations earlier on. Ronald's going to speak to you about care homes, but actually our care home population, about 25% of people in a care home will die each year. And how important it is to be able to support care home staff, people in care homes and their families, to have really good conversations about what their wishes would be as they approach death. I'm going to break a little bit to talk about this gentleman who is my dad. I don't often speak about my dad at conferences, but I wanted to talk about him because as a family member, as a daughter, he was, I'd always say that about your dad, he's obviously very special, but he sat us down. He was diagnosed as being diabetic at the time he retired just after 60, and got on with it and just lived very well. He did modify his diet, he lost weight, he was more active. And about the time of 80, when he was 80, he was really beginning to struggle. He'd lost a lot of sensation in his feet and his mobility was going. And he sat us down as a family with my mum and my brothers and really talked to us about what he wanted. And what he wanted more than anything, if possible, was to be at home. He was happy that if he needed extra care, that he would have that extra care in if it was possible. But what he said to us, if at any time the burden of the care was too great for my mum, we were to, whether he wanted to or not, we were to put him into a different environment where she could get more support. And by doing that, and despite having a heart attack that required him to go into hospital urgently and to come out again, and he fell, he had dramatic dips in his functions. He rewrote his will, he did a power of attorney. So as he deteriorated, we had very clear idea about his wishes, but also we had the practical things wrapped around him that enabled us to do that, so that as he became less able to access his bank accounts and do the financial management, which he'd done all his life, one of us was able to take that on. And he had minimal involvement with his GP. His GP was great, but actually he didn't need very much. And we had a great last 6 months of his life where they celebrated their diamond wedding, which he was absolutely focused on. And we drank lots of champagne. He was 85. We drank even more champagne. And then three days before he died, Scotland beat France at the rugby, and we had even more champagne. That was great. But it wasn't all good because actually, although he very much did this, and he died, we had lunch the day before he died, and he died very peacefully in his own bed, as many of us would like to. But actually, it was the time before Living and Dying Well came out, and there was very little communication between his GP and the out-of-hours service. He died at 5 o'clock in the morning, and I phoned NHS 24. My mum phoned me, and I phoned NHS 24, and I was about 40 minutes drive away. And by the time I got there, the GP had come, but because there was no history at all available to the GP, the GP classed my dad at the age of 85 of having a sudden death, and I arrived at home with 2 policemen sitting with my mum. So it was fine. The policemen were great, you know, and they were embarrassed. They could see that this was an unexpected death, and we all waited until the GP practice opened up and the GP was able to confirm it and do the death certificate. So even with the best planning, you know, it doesn't all go all according to plan, but my goodness, it does help. And I think what I'd really like you to get into conversations today is actually at the very end of life, perhaps there are fewer choices, but actually your choices come by talking much earlier as individuals, within your family, within your society, and with each other. And to back this up, some of the things just that we've done with Living and Dying Well, there was a wonderful piece of work. If you're interested, there's a palliative care zone on NHS Inform that was actually built up with some, mainly with people from public, representing people from the public, talking about what is it, how to control your symptoms, about issues about babies and children. And then going on to very practical help. So as you're coming to the end of your life, or perhaps have got lots of diagnoses that make it difficult to get travel insurance, where can you get travel insurance? If you're on opiates or pain relief that are strong, what's actually the guidance that you need about driving? What about making a will? What about your power of attorney? So again, if you're interested, the information is there. I'm not going to go into the individual actions of Living and Dying Well. You can read them, we can talk about them. But I think the approach that we've tried to take is a very practical one and built up and supported by education, as you would imagine, about some of the hooks and levers that can enable change across a complex healthcare system. We've got some very, very good tools that do share information. So in the situation of my dad's death, now I hope wouldn't happen because he would have been identified as having on a palliative care registered with his GP with consent. He would have given information for his GP to share some of his information for NHS 24, the out-of-hours service and the ambulance service. And in this situation, therefore, the doctor who came to support my mum and to confirm death at 5 o'clock would have known that this was an unexpected death, and we would have done it differently. We have do not attempt cardiopulmonary resuscitation policy, which I'm happy to take questions on later. And obviously there's been a lot of interest in the media and some very difficult things for us to do around about the Liverpool Care, the dying pathway. And again, I'm happy to have those conversations. But I think really importantly, what I would like to really listen to today, but encourage you all, is actually share your experiences about what it is that makes a difference to you and your family. Here in forums like this, through the Patients Association, but also the Scottish Government has just announced a really opportunity to look at the Patient Opinion website and actually to give informal feedback as you experience care. And I'd really like to support that as a way in which we can really understand people's experiences of death and dying. And I think the other thing that we're going to do in Scotland is do a kind of a more formalised gathering of people's experiences of death within Scotland, so that we can really make sure that any energies we put into future improvements are based on what people are saying. As with any kind of national action plan, we're very aware there is variation in application. And there's variation in the way that doctors communicate between themselves and particularly with people. There are enormous pressures within our acute hospitals at the moment, and with the numbers of people coming in, the complexity of the care that is required. And I think, again, you cannot not have actually been aware of the very distressing stories that have come out of England about the Francis report, and also kind of a lot of the media coverage about the Liverpool Care the Dying pathway. And again, very happy, I'm quite interested to get into those conversations so that we can share and share learning. And there are a number of people in here who are passionate around about the education and training and support of health and social care staff, both at junior and at senior level, to get this better. There is, I think, a real difficulty or a challenge for staff within a healthcare system to actually have difficult conversations. And I think if you think of the age group of many of the doctors and nursing staff that are having and trying to support people who are deteriorating and facing uncertainty, many of them are young. And I think there are enormous pressure. The speed of turnover now within our acute sector is very, very high. And so it is difficult. What happens if people get upset? It is a really difficult one to support junior staff in getting into conversations where they are going to raise issues of uncertainty or raise issues around about potential about death and dying, to actually support people, allow them to be distressed and to have time to talk, and also to be able to manage to get out of those conversations well so that people continue to feel supported. And there are some that are better than others. What it says here, this is difficult for me to explain, so I brought a prop. And we need to make sure that we educate and we support people, but there will always be some people that are better than this than others. And also there has been, this is an example of an article, is the wife's fury at death order, family handed form telling doctors not to revive husband. That's an awful thing, isn't it? But actually, if they put wife's fury at order to ensure a natural, peaceful and dignified death at home, doesn't have the same impact. So this is around about do not attempt cardiopulmonary resuscitation. So if someone is expected to die, the natural ending of that person's life is at the point where the heart stops. And at that point, if you were to drop from a heart attack in the street, you would absolutely want somebody to be able to give you cardiopulmonary resuscitation. This is the actual resuscitation of the heart. But actually, if you're coming to the end of your life, this won't work. This will not work. And if you try to resuscitate actively somebody at the end of their life, you cause immense distress to the people around about them and actually are getting engaged in a treatment that is futile. And so that's the premise behind the national DNA CPR policy. 13% of cardiopulmonary resuscitation attempts in hospital work. 13. So that means that 86% don't work. So we've got some better thinking to do about this. And I think there has been, we just touched on the LCP. The LCP is a framework, a tool to support staff to work together as people are recognised to be dying. There has been a lot of media interest in this at the moment. And I just want to, it's not a busy slide, but it's, what this was in the British Medical Journal last week. And is your experience, has the recent negative press coverage of the Liverpool Care of the Dying pathway led to it being used less? And here you can see that both in consultants in palliative medicine, doctors working in other specialties, and all doctors working, the blue line is yes, it has had quite a significant impact. And the concern I think we all have, and we had a big national advisory group palliative care meeting yesterday, is that this tool itself is actually harnesses or enshrines best practice that was developed out of the hospice movement to be available to support generalists in delivering really good care. And the last one, in your experience, has pressure on resources influenced decision to use the LCP? No, so there's no financial implications around about this. But I think at the moment we're in a situation where we have got a very good tool that has some very difficult issues associated with it. I think kind of Rosalie Dunn was talking yesterday that many of the experiences of people will always have something around about them that we need to learn from, particularly around about the communication and the discussions and the regular discussions and review that we all should be having with people as they are dying in those last few days of life. But just this will, my concern is that particularly for junior staff, this can have quite an impact at the moment, and we need to think about how in our roles as more senior clinicians and people working in the health service, we can really support people at the moment. And how we care for the dying is an indicator of how we care for all sick and vulnerable people. And my last bit of my talk is about society as a whole. And it is a measure of society as a whole, a litmus test for health and social care services. I really think that's just a wonderful couple of sentences to capture how important this aspect of living and dying is, and how we should perhaps as a society think much more about this and talk much more openly about it in days like this. And I'm just going to use a couple of slides from Harry Burns now. Again, our health and social care services are much more predicated at focusing on problems and needs and deficiencies. And as a result, communities feel disempowered. People become passive recipients of service rather than active agents in their own care. And that's what I really want to see, if we can create an energy about people actually having conversations like we did with my dad, how much more empowered I think we all felt to be able to deliver the care or be engaged in those conversations, than actually being disempowered by being part of a busy hospital system and not knowing the language or the different words that we could use about death and dying. And Harry's very keen, and Harry Burns, on looking at a health asset, which is any factor or resource which enhances the ability of individuals, communities and populations to maintain their health and sustain well-being. And the assets can operate as a protective and promotive factor to buffer against life stresses. Life is always going to throw us challenges. And buses never come in ones, do they come in threes? And certainly in all the work I've been doing as a GP, many families do all right after one death, but actually after two, after three, perhaps some issues around about finances, it really does exhaust people. And I just want to raise the issue of Good Life, Good Death, Good Grief. It's an organisation hosted by the Scottish Partnership for Palliative Care, really looking at how we can actually look better at actually recognising the unnecessary harm that is caused because people in Scotland are not open about death and dying, and that people who are dying can experience isolation, people die without wills, healthcare professionals struggle to have conversations, and the fact that someone that is dying is not acknowledged, then opportunities to resolve issues and say goodbye can be missed. And I'm sure you've all got experiences of that. And just a snapshot survey is that 74% of people have not discussed what their wishes would be if they didn't have long to live. 61% of people, this is because they feel too young to discuss death. And 79% of Scotland don't have written plans for their end-of-life care, financial wishes or funeral plans. And only 35% of people have written a will. So I think there is a role for government to really work with local authorities, the NHS and the third sector in making sure that systems and processes, education, training, resources are available. But I think there is something about actually, can government really enable individuals and that social connectedness within our communities, looking to hospices to really lead the way, actually to really get engaged with schools, with groups, to volunteering, think about how as a society we can really come together, be more socially connected and have a greater opportunity to make choice so that we can continue to live and also we can choose to die well. And very much at the end, this is a picture of where I live. I'm going to, if I've got time, just literally read out some words that were given to me by one of my patients as she sat with her mother who died in a hospital. The visitor. The snow fell softly and voices were hushed in the whiteness. It was a different world outside the ward. The world outside waited for Christmas and birth as we waited for life to end. It was so much safer in the hospital. There was no need to pretend to be cheery, and no need to hide the tears which stung my eyes so readily. I was relatively familiar with death, having lost friends, relations, my father. However, I had never met death, and that's the difference. I had never sat with life and waited for the inevitable and unwelcome visitor who would come all too quickly and take my mother to an unknown place. I rewound the video of my life, put the pause button on all the good bits, sometimes laughing, often weeping. I walked and talked with my mother through 60 years and gave thanks for the gift of memory. The ward was my sanctuary, the nurse my companions, my doctor my anchor. I was on a bridge between the real world and this anteroom of death, which became a place of life, honesty and blessings as I shared the last precious days. Gradually, she slipped off somewhere I couldn't reach her, resting peacefully. Conversation was now one-sided, but still real. I sat, watched, waited and wondered, waited and dreaded this unwelcome visitor. I didn't know what to expect in these final stages. I was uneasy about the rattled breathing and the fluttering heartbeats. I didn't like the impotence of my situation. Yet I was empowered by being there, by having the privilege to wait. I had the privilege to see my mum cared for with dignity and compassion. I had the compassion of human comfort and the freedom to be who I was with unconditional acceptance. But I didn't like the rattle of death. This visitor was getting close. The snow fell fast. Where was my mum in this rattling chest and laboured breathing? She was like a bird fluttering at a window, wanting her freedom. The visitor came in quietly as on the wings of a dove. He didn't scare me or mum, and he left just as silently. I watched the pulse on her neck stop, and by the time I kissed her cheek, she was already on the other side of time. The snow still fell. It was Christmas Eve. Birth and death became one and the same. Thank you.